Welcome to Complete Anatomy. My name is Dr. Alan Detton, and in this lecture I'll be going over an introduction to the skeletal system. At the end of this lecture, you will be able to state the general functions of bone and cartilage within the skeletal system, list the bones comprising the axial and appendicular skeleton, recognize different types and classifications of bones and describe their general locations, describe typical features of a long bone, and list and define articular and non-articular bone markings. Introduction to the skeletal system. The skeletal system is designed to support soft tissue structures, and soft tissue structures could include the muscular system or potentially either the arterial or the venous systems. So these are all examples of soft tissue in our body that without the rigid skeleton for support simply wouldn't be able to maintain their position or play their key role in our body's function. Now, the skeletal system is also going to play a really important role in protecting some of the vital organs. And we're going to take a closer look at that as we look at the two different components of the skeletal system. The first is the bone. Now, bone is going to be responsible for the actual protection of the soft tissue structures in our body. Now, if I were to turn on the respiratory system, for example, you could see that our lungs are going to be protected within the skeleton of the thorax, as would be our heart if we were to turn on the arterial or venous system. So this is going to play a key role in keeping those vital organs of the heart and lungs well protected. Additionally, if we were to take a closer look at the head and use one of the tools to cut a window into one of the bones of the head, we could see that the skull is going to play a key role in protecting our brain. So these are what I mean by the vital structures or vital organs: the heart, the lungs, and the brain. Things to keep you alive, and if you didn't have the skeleton there, you wouldn't be able to protect those soft tissue structures. Now, the other function that we're going to see of the bone is going to be able to provide support for the muscles of the body, primarily the skeletal muscles of the body. And if we turn on the muscular system, you can see these different muscles, and you can hide them and turn them on or off to better understand their relationship with the skeleton. Additionally, you could actually turn on different layers or color maps for the skeleton to see the parts and the surfaces, as well as the sites of muscle attachment, which will give you a better idea of which muscles are going to attach at which locations throughout the body. Now, the other thing that we're going to see with the skeletal system, in particular the bones, is it's going to play a key role in storage of different minerals in our body like calcium and phosphorus, and it even plays a key role in production of red blood cells. And this is going to occur in the actual marrow of the bones, and we'll get into more detail about that later on as well. Now, the second component of the skeletal system is going to be cartilage. And cartilage is going to be a semi-rigid type of connective tissue that's quite resilient. However, it's going to still provide a lot of support while allowing a little bit more flexibility. And there are multiple types of different cartilage that we'll explore throughout this lecture. We're going to see that cartilage is going to line the ends of the long bones. It's going to act as a shock absorber between the different vertebrae in our body. It'll play a key role in the rib cage in allowing movement. And it's also going to be a component of our developmental process. And what we're going to see is that babies have a higher percentage of cartilage than adults. And this is because they're going to not only have smaller bones that have yet to fully develop, but they also have a component within the bones themselves known as growth plates. And these growth plates are going to be made of cartilage, and they'll be gradually replaced by bone as we age. Now, the last thing I want to mention is that cartilage differs from bone in that it is avascular tissue, meaning that it doesn't have a direct source of blood supply like many of the other structures in our body. There are 3 different types of cartilage found throughout our body: hyaline cartilage, elastic cartilage, and fibrocartilage. Now, these different types of cartilage are going to have different characteristics and different functions. So let's begin by taking a closer look at the first of these types, which is the most abundant throughout our entire body and the most variable. And this is hyaline cartilage. Now, hyaline cartilage is going to be found in a lot of different locations. It's going to be found where our ribs meet up with our sternum, for example. So this forms the costal cartilage. So in this case, it's going to help protect the anterior aspect of our thoracic wall and thus protect our vital organs. We're also going to see that hyaline cartilage is going to line the ends of our long bones. So where one long bone meets up with another long bone, we're going to need a protective layer that is very smooth, that reduces friction within the joints. We're also going to see that hyaline cartilage has some specializations within our head and neck. For example, this is the type of cartilage that builds up the end of your nose or the tip of your nose. So it's going to help keep the airways open and form the structural support for the distal extremity of your nose. We're also going to see hyaline cartilage within our throat, within the larynx, in the laryngeal cartilage, as well as the airway of the trachea. Lastly, we're going to see that hyaline cartilage is the precursor for bone. And what this means is that this is the layer that gets gradually replaced by bone within our growth plates. The next type of cartilage is far less variable and found in more specific locations. The name of this is fibrocartilage. Now, fibrocartilage is more dense than hyaline cartilage, it's less flexible, and it's going to be in a structural supportive type of role. So we can see an example of fibrocartilage here at an intervertebral disc. Now, intervertebral discs are actually going to be made up of 2 different layers: an outer fibrous ring that is made of fibrocartilage, and an inner nucleus pulposus, which is like a gelatinous bag to help act as a shock absorber. So just the outer aspect of this is made up of fibrocartilage. Now, what we're going to see is that fibrocartilage is also going to be found where bones need more support. So we will see this within the ligaments of our body that are attaching from one bone to another directly. We will see fibrocartilage also at the pubic symphysis, the point anteriorly where the right and the left hip bones meet. Fibrocartilage also surrounds and protects our joints by forming the joint capsules. Another key location to find fibrocartilage are the cartilaginous pads between our bones of our knee. These are the menisci. So again, these are going to act like shock absorbers, similar to the intervertebral discs where we need more cushion and support for these weight-bearing bones within our body. Now, the last type of cartilage that we're going to see is the most limited in its organization throughout our body, and it's going to be the most flexible type of cartilage, as its name would imply. This is elastic cartilage. Now, elastic cartilage is going to form the auricular cartilage in our ears. So you could see an example of its mobility by grabbing the top of your ear and simply pulling it down, and it will bounce back up to its previous shape and its original appearance. We're also going to have epiglottis where we need a lot of movement, like we see here in the epiglottis and some of the laryngeal cartilage. So this is an area that needs to be able to move to direct fluids and solids from the mouth down into the esophagus and away from the airway. So again, it needs to be able to bend frequently but maintain its original shape. Axial versus appendicular skeleton. There are two subdivisions for the bones within the human skeleton. These are going to be based on their location essentially and their relationship to the mid-sagittal or median plane. Now, if we were to take a look at the bones which are going to cross the mid-sagittal plane, we can see that these are going to be the bones that are going to primarily form the grouping that we are going to consider the axial skeleton. Now, the bones of the axial skeleton are going to consist of the bones that we find in the head and neck, as well as in the thoracic region, and continuing down into the lumbar and pelvic regions along the midline. The bones of the skull are going to help to serve two different functions. One, going to keep our airways open, and also they're going to help protect the brain. The cervical vertebrae, continuing down the vertebral column, are going to serve a key role in protection of vital organs and structures like our spinal cord, as well as a lot of the internal organs within the body. Now, the vital organs are also going to be protected by the thoracic region. So the bones here that we see in the thoracic region of the sternum and the ribs are going to serve a key role in protecting our lungs and our heart. So the axial skeleton is going to be this midline grouping of bones as well as the rib cage or thoracic cage. Now the other subdivision is going to be the appendicular skeleton. So the appendicular skeleton is going to be the rest of the bones in the human body. And what we can see here is these are going to be the bones that are forming the upper limb and the lower limb. So supportive roles in movement and control of how our body is positioned is primarily going to be the responsibility here of the appendicular skeleton. Now we do have a lot of movement in our thorax. We can bend at the waist or the hip and position our body better. But a lot of that movement is going to be done out here in the periphery with this appendicular skeleton. The bones in the appendicular skeleton are going to be connected back to the axial skeleton by girdles. Up here by the shoulder, we can see that the clavicle and the scapula are going to be the two bones that are connecting the upper limb back to the axial skeleton. And thus these two bones are going to be our shoulder girdle, also known as a pectoral girdle in some textbooks. Inferiorly, the bones of the lower limb are going to be connected back to the sacrum by our hip bones, otherwise known as the os coxae. So the os coxae, or the hip bones, are going to be key bones for weight transfer from the lower limb and provide a lot of stability for the movements that are required to help us be bipedal creatures. Types of bones. There are two different types of bones, which is going to be different than the classifications of bones. If I were to take a closer look at any single bone within the body, what I would see is it's going to be made up of the two different types of bones. And what I mean by that is better visualized if we were to take a cross-sectional piece out of one of these bones. And here we can see in this cross-sectional view, or the cut edge of that bone, the two different distinct appearances of the types of bone. Surrounding the edge of the bone is compact bone, also known as cortical bone, and this is made of a solid bony matrix. The solid bone is quite dense and strong and is primarily responsible for supporting the weight of our body. Now, compact bone also stores calcium, which is the principal molecule responsible for hardening this type of bone. The second type of bone is spongy bone, also known as cancellous or trabecular bone, and this is going to line the inner edge of that cortical or compact bone. Now, to better illustrate what this type of bone looks like, I'm going to bring in another image that is under higher power magnification. And here we can see the two different types of bone. Lining the outer edge of the bone is going to be the compact bone, while the spongy bone is going to line the inner aspect of that cortical bone, and it's going to surround an area known as the medullary cavity. Now, the medullary cavity is where we're going to find the bone marrow, and that's typically full of the spongy bone. Now, as we can see, there's a difference in appearance between this cortical or compact bone and the spongy bone. And one of the most noticeable differences is the difference in surface area between these types of bone. Now, if I were to remove this image and take a closer look at a bone after the disease process of osteoporosis. Now, osteoporosis is going to be gradual bone loss following a depletion typically of calcium within the bones. And this is going to start within that spongy region of the bone in most cases. So as we start to weaken the spongy bone, it's going to destabilize the cortical bone that surrounds it on its edge. So if an elderly individual were to fall down after having osteoporosis, it's quite common to see fractures present within the bone itself. And this is due to that destabilization of the skeletal matrix within the bone itself. There are multiple classifications of bones, which is different than the types of bone. Recall that the two types of bone were either compact or spongy bone. Now, these two types of bones are going to be found within all of the different classifications of bones. So let's first take a closer look at the easiest to identify classification of bone, and those are the long bones. Now, a long bone can be quickly recognized as it is longer than it is wide. These types of bones are going to have a long central portion, known as a shaft, and then two enlarged ends where it meets up with the other bones. Now, simply because of its overall length does not necessarily mean that it's going to be a long bone. However, the majority of the bones within the limbs are classified as long bones. What you may not be aware of is that the bones in our hands and feet are also considered long bones. Here we can see that the metacarpals and the phalanges follow the same pattern, where they're going to have a longer length than they are wide, and they're also going to have a central portion that is thin and long with two enlarged ends. The next type of bone that we should compare this to are short bones, which are approximately as wide as they are long. Now, these types of bones are the bones that we're going to find within our wrist, for example. So the carpal bones, these small bones within the wrist, are classified as short bones. So they're approximately going to be as long as they are wide, and they have mainly a supportive role. So these are the types of bones that support and stabilize our body with little movement. So they're going to be found at our wrist and our ankle in the carpal and tarsal bones. The next type of bone that we'll take a look at are flat bones. And a flat bone, as its name would imply, is going to be relatively flat. Now, they're still going to follow a similar pattern of having both compact and spongy bone, and they're arranged sort of like an Oreo cookie, where we're going to have compact bone, then spongy bone, then another layer of compact bone, which will help you with identifying their style or type. Now, these classifications of bones, the flat bones, are mainly going to be for protection. So they're the types of bones we see in our skull that protect our brain. They're also going to be the ribs, which are going to protect our thoracic organs, as well as the sternum. And then we can see some of the bones like our shoulder blade or aspects of our hip bones
that have characteristics of these flat bones. Now, some bones don't fit in the classifications of long, short, or flat, so they are called irregular. And I can see two examples of irregular bones here. The hip bones have a very irregular shape. We're also going to see that the lumbar vertebra and all of the vertebra are going to have a very irregular shape when we compare that to other bones of the body. So these that have peculiar or complex anatomy are going to be considered part of the irregular bone classification. Now, the last type of classification that we're going to look at are the sesamoid bones. And sesamoid bones form within a tendon that crosses over an angle. And what we're going to see here is that the patella is a great example of this. This is a bone that forms within the quadriceps muscles that helps you flex and extend your knee. We're also going to have small sesamoid bones near the base of our thumb and at the base of our great toe. So these small bones here are also going to be considered sesamoid, that they form within a tendon. So remember the different classifications of bones as you study the bones of the human skeleton. When we look at the human skeleton, one of the bones that we most often think of are the long bones. These bones that are going to be found within our limbs that are longer than they are wide. And these bones are going to be found in the large components of our limbs like our thigh or our arm, but they're also going to be the smaller long bones that we find within our fingers or our hands and feet and toes. So just because it's not a certain length does not define it as a long bone. Rather, it's going to have characteristics that are continuous with this type of bone that is longer than it is wide. So let's take a closer look at one of these in particular and look at the different parts of this long bone. The main characteristic of these bones is that we're going to have a long central portion known as a diaphysis or a shaft that is going to be capped on either end by an enlargement of bone, the epiphyses. So we will have a proximal enlargement known as the proximal epiphysis and a distal enlargement known as the distal epiphysis. Now, in between these points of enlargements and the central shaft of the bone, we're going to have another component of the bone, and that is the metaphysis. And these are the locations within the long bones of where we had growth plates. So as a child or an adolescent, we're going to have cartilage forming a layer or a line within these long bones. And as we grow, there's going to be bone that lays down in the place of the cartilage and pushes the ends of the bone, the epiphyses, further away from one another. At a certain point in growing up, those growth plates are going to fuse. So the metaphysis is no longer going to contain cartilage, but will all be replaced by bone. And that is what's going to determine how long these bones get. Now you'll notice that at the ends of the epiphyses, we're going to have a smooth surface, both proximally and distally. This is known as the articular surface. So the articular surface is going to be the ends of the bone that get lined by hyaline cartilage, so that we're going to have a nice smooth area for reduced friction between bones at our joints. There are a few other key characteristics of the long bone that I'd like to take a look at by cutting a cross-sectional cut through the humerus. By doing so, we can see that there are going to actually be layers to this bone. So I want to just cover a couple characteristics of all bones, and those that are particular here with the long bones. To begin, the outer aspect of all of these bones is going to be lined by a layer of connective tissue that is known as periosteum. Now, the periosteum is going to line the outer aspect of these bones. It's going to surround the tough, dense bone that provides the strength and support of these bones, which is the compact bone. And we can see here that the compact bone forms the outer edge of this cross-sectional cut. Deep to the compact bone, we're going to have the spongy or cancellous bone that will be immediately deep to the compact bone. And this is going to start to surround an internal space known as the medullary cavity, also known as the marrow cavity. So the marrow or medullary cavity is going to be the central portion of these bones, and it's going to be lined by a layer of specialized cells known as endosteum. And this will surround the hollow central portion of the bones, which is either going to contain fat and be yellow marrow, or red blood cells, which we would consider red marrow. So the bones are going to be developing either red blood cells or part of our lymphatic system and parts of our immune response within the medullary cavity. And the way that those cells get in and out of the bone are through small openings known as nutrient foramens. So especially in the shaft of a long bone, you're going to see small openings that would allow for the passage of blood vessels and nerves in and out of this space. Intro to skeletal terminology. Skeletal terminology is a list of words that are going to be descriptive for certain characteristics or components of anatomy that are only related to the skeletal system. For example, we're going to see that there are specific prominences or extensions of bone that are going to serve different purposes on the skeleton, and anatomists like to name things, and so we've given them all different names. Now, to help you understand what they are, I recommend you turn on the parts and surfaces of the different bones and look at these color maps as you explore through the app. Now, the first of these terms is a process. Now, a process is going to be an extension of bone. And there are multiple types of processes. We're going to see here on one bone, we have a transverse process, a spinous process, an inferior articular process, and a superior articular process. So these are going to be different extensions of bone. And some of them are going to be meant for sites of muscle attachment, while others are going to be aiming towards another bone and a point of articulation. Now, we're also going to see other names for extensions of bone, and one of them in particular is going to be given its name because of its sites of muscle attachment. And here we're going to see a tuberosity, and this tuberosity in particular is known as the radial tuberosity, and it gets its name for the bone that it's on, the radius. A different tuberosity is going to get its name for the muscle that attaches there, which is the deltoid tuberosity. So this is a roughened area of bone meant for muscle attachment as well. Now, we're also going to see other extensions of bone that vary in size and hence are going to get different names. For example, we're going to have a tubercle, or a small bump, that is going to be between our ribs and the vertebra. We're also going to have a tubercle that is a large bump out here on the humerus, and it gets the name greater tubercle or lesser tubercle depending on its relative size to the other bump. Now, we're also going to get very large extensions or prominences of bone that are known as trochanters. So here on the femur, we're going to see a greater and a lesser trochanter. Now, not all of the bony landmarks are going to be for muscle attachment. For example, some of these are going to be depressions in the bone. We're going to see that the fossa is going to be a smooth depression within the bone. And if we were to look at the surfaces, we see this large area that is also going to be for a site of muscle attachment. And we could come up here to the scapula, and we're going to see that it also has different fossa or depressions where muscles will sit. Now, a foramen, on the other hand, is going to be an open area that does not have anything attaching at it necessarily. It might attach on the rim, but a foramen is going to be the actual hole through the bone. And these foramen are going to have different names based on their location and sometimes the contents that it allows to go through it. Now, we're also going to see that there are going to be terms related to grooves or depressions. So remember that we had a greater tubercle and a lesser tubercle. Well, in between those, there is a depression known as the intertubercular sulcus. So that's going to be named for the depression between those large bumps. And I know that this is a lot of new terms and words that you haven't heard before, so you're likely going to need to re-watch this a couple of times until you get them all down. The majority of the terms that we've looked at so far for skeletal terminology are related to points of muscle attachment. And now we're going to take a closer look at some of the bony landmarks that are either just generic or related specifically to where one bone meets another. The first of these is going to be related to a long bone, and the head is going to be one of the ends of that long bone. Now, the head of the long bone doesn't necessarily need to be at the proximal end. For example, we can see that some bones this is the case, like with the femur or the radius, which is going to have its head proximally, or even the humerus, which has its head proximally as well. However, the ulna is going to have its head located distally. So the head is simply going to be a rounded prominence or projection of that bone. Now, near the head is going to be the neck. So this makes some sense just based on your everyday terminology that we would find the neck below the head or in near proximity to it. Now, additionally, long bones are all going to have a central portion, otherwise known as the shaft. Now, on the ends of the bones where they meet one another, we're going to see that there is a smooth surface, and this is known as the articular surface. So the articular surface of the head of the femur is going to be the part of the bone that is actually going to meet up with the other structures in the area. So if you turn on the different parts and the surfaces of the bones, you're going to be able to see what those terms are. Now, the facet is going to be a specific type of articulation, and facet means face. And where we're going to find facet joints for the most part is where we're relating either to the ribs or to the vertebral column. So here we're going to have a superior articular facet. So it's given a very specific name to let us know it's on top, superior, articular, it's related to a joint, and it's a facet, the smooth part of that piece where they meet up. So a facet is going to be a specific type of smooth surface where you can see one bone overlapping with another here in the vertebral column. Now, a notch is going to be found in more particular places. Here we can see the ulna would wrap tightly around the humerus, and it would have a notch to fit around that component of the humerus where the two bones meet. Additionally, we're going to have certain bones that are going to have a condyle, which is going to be an extension of bone that is in specific locations on the opposite end of where the head was for certain bones. Recall that on the femur, the head was located proximally, so the condyle is going to be the opposite end of that bone. Now, some of these bones, like the humerus, are also going to have a very definite or pronounced projection known as an epicondyle, which means on top of the condyle. So again, the humerus is going to have a head at one end, a shaft, and then it's going to have condyloid type projections, which would have an epicondyle sitting on top of them. Now, there's a lot of different terms that you're going to learn as we go throughout this course, and I highly recommend taking the time to explore the skeleton and familiarize yourself with the different parts and surfaces, as well as these terms that I've just introduced. Hello, my name is Dr. Alan Detton, And in this lecture, I will be going over an introduction to the joints. By the end of this lecture, you will be able to list and define the major classifications of joints as fibrous, cartilaginous, and synovial, and provide examples of each. You will be able to describe the major features and defining characteristics of a synovial joint. And lastly, identify the different types of synovial joints: hinge, pivot, saddle, condyloid, plane, and ball and socket, and provide examples of each while listing the movements allowed. A joint is defined as a point at which two or more bones articulate, meaning where they meet up and come in contact one with another. Now, despite what you might think, not all joints actually need to move, so it's simply going to be a point where the bones meet or articulate again that makes it a joint. Now, we can classify the different joints throughout the body in two different ways. We could look at them structurally, meaning what are the pieces of connection formed by, or functionally, looking at what kind of movement they allow. So we'll be discussing the movements that are allowed at each joint, but primarily we're going to look at them as a structural type of subdivision. So we're looking at what physically is connecting these together. And for this type of organization, there are three different types of joints. The first are fibrous joints. Now, a fibrous joint is going to be where they're connected by tough fibrous tissue, and we'll look at this in more detail. But predominantly, these are not very mobile. A synovial joint, on the other hand, is quite mobile. These are the types of joints that we really think of when we look at the joints throughout our body. And there's going to be certain characteristics of how these types of joints are formed and what makes them. So we're going to spend a lot of time looking at synovial joints. Lastly, we're going to see cartilaginous joints. And as their name would imply, these are going to be connected by cartilage, in particular fibrocartilage or hyaline cartilage. And so these are going to be excellent shock absorber type of joints, and we'll see examples of them throughout this lecture as well. Fibrous joints. Fibrous joints are connected by fibrous connective tissue, as its name would imply. Now, fibrous connective tissue is really strong, it's often quite dense and inflexible, and thus allows little to no movement. A fibrous joint is also known as a synarthrotic joint or a synarthrosis. The terms syn and arthros mean respectively together and joint. So a synarthrotic joint is a type of joint that allows little to no movement, as the bones or the structures are in very close contact to one another. What we'll see is that there's actually three different types of synarthrotic joints. The first of them that we're going to look at is a suture. And sutures are going to be found between the various flat bones of the skull, and their primary role is going to be to protect the underlying brain. So you can imagine that these bones are going to need to not move in order to serve that all-important function. So there's a couple of key characteristics that these bones, or in particular the sutures between the bones, have to help serve this role. Now, the first of which we're going to take a look at is the increased surface area of these bones. And what I mean by that is if you were to draw a straight line and picture that these bones were interacting one with another along that straight edge, there's going to be a limited amount of points of contact for those two bones, and it could even allow a certain amount of slipping or movement. Now, if I were to take the same length of line and curl it or bend it, it's going to have more points of contact, and it's going to allow a lot more stability where these bones are going to interdigitate or interlock, kind of like your fingers if you were going to place them against each other. So this interlocking pattern is very characteristic of sutures. The other thing that sutures are going to have to help reinforce and strengthen them is the actual connective tissue. Now, all bones throughout the body are going to have a lining that is known as periosteum. And the periosteum here is going to extend from one flat bone to the other. And it's actually going to extend down into those thin cracks between the adjacent bones. So you can imagine that the periosteum, or the lining of the bone, is going to extend down into these fine, thin crevices and increase the contact and connection points between those two adjacent bones. And so basically what we're going to have is a reinforcement on the outer surface, between the bones themselves, and actually it's going to also be on the inner surface. So if I were to hide one of these bones and the brain itself, and we were to picture this on the inner aspect, now what we're going to see is that there's going to be a continuous layer on the inside of the skull as well. And here the periosteum gets a specific name. It's known as the periosteal layer of the dura. However, it serves the same function. It's going to be the connective tissue extending from one bone to the other and connecting with the connective tissue in the actual suture line. So this is going to be a really key factor in strengthening and reinforcing these different joints along the suture lines of the skull. Now again, recall that the primary purpose of these bones in this region where the sutures are is to protect the underlying brain. So there's going to be bones that help form the skull base or the cranial fossa, the floor of the skull, on the inside, as well as on the superior aspect, forming part of the calvaria. Now, these we'll get into in more detail later on, as well as the functions of the bones in the face, which help to protect the eyes, maintain the openings of the nasal and oral cavities. But just remember that these sutures are going to be the specific joints that are going to be forming here between the bones of the skull. The second type of fibrous or synarthrotic joint after sutures is also found within the head, and this joint is known as a gomphosis. Now, a gomphosis is going to be the joint that is formed between the roots of our teeth and the surrounding bone, either the mandible or the maxilla. And what we will see is that each individual tooth is going to have its own socket. So if we were to draw using our 3D pen tool, we can draw the outline and basic shape of one of these sockets. And what we'll see is that the socket is going to extend down into the surrounding skeletal structures of the mandible or the maxilla. And attaching from the socket to the actual root itself are small ligaments. And these ligaments are known as periodontal ligaments. And the periodontal ligaments are going to be responsible for keeping that tooth held firmly in place within our oral cavity. Now, as all of you are likely aware, there is going to be two different sets of teeth that grow during development. We often refer to these as primary or baby teeth and secondary or permanent teeth. Now, the primary set of teeth are actually in the oral cavity, or I should say will be already formed within the baby at birth. However, they have not yet extended out into the oral cavity and have not yet erupted. So what we would see is the actual tooth would be sitting deep to the gums, but it would actually already be present within either the mandible or the maxilla. And as the teeth begin to grow, they are going to erupt typically around the age of 6 months old. And I'm going to go out on a limb that most of you don't remember your own teeth growing in, but if any of you have children or ever been around a baby, then you know that the process of teething can be quite painful. Now, as we grow, our primary teeth are going to fall out, and they are going to be replaced by our secondary teeth later in life. Now, this is usually going to begin around the age of 6 or 7 as our primary teeth start to fall out, And by the age of 10 to 13, our adult teeth are going to grow back in. Now, what we're going to see is that this process is incredibly complex, and we don't really need to get into that much detail today. But for our purposes, I just want to emphasize that the root of each tooth is going to be responsible for holding that tooth firmly in place with the surrounding bone through the periodontal ligaments. So if there's no root, there is no ligament to then hold that in place. Now, the third type of fibrous joint that we're going to actually take a look at is going to be found in the extremities. And this third type of joint is known as a syndesmosis. And a syndesmosis is going to be found between the long bones either in the forearm or in the leg. And what we're going to see is there's a strong fibrous connective tissue sheet that is going to be extending from these long bones within these regions. And in the leg, it's going to be found between the tibia and the fibula. And the primary role of this is to prevent these bones from separating from one another. So we don't want there to be any ability for the fibula to move away from the tibia. And especially this is going to be important for stability at the ankle. Now, as we come up back to the forearm, what we're going to see is there's going to be a fair amount of rotational movement that is going to be allowed here at the wrist, but we want to keep the bones close to one another in this region as well. The primary stability at the wrist is a little different than at the ankle, and we'll see that later on. But I also want to emphasize that the syndesmotic joints, or specifically these interosseous membrane, are also going to serve as sites of muscle attachment. So the bones are not going to be able to separate, and the surrounding musculature can attach to these strong fibrous connective tissue elements that we're going to see as part of these syndesmotic joints. Cartilaginous joints. As the name implies, cartilaginous joints are joined by cartilage. And the two types of cartilage that are going to join these joints are either hyaline or fibrocartilage. And this is going to determine which type of cartilaginous joint it is. Now, a cartilaginous joint is also known as an amphiarthrotic joint. And this is different than a fibrous joint in that it has a little bit of movement. Whereas a fibrous joint was immobile, these have a slight amount of movement within the joint. Now, what we're going to see is that there are two different types of cartilaginous joints depending on the type of cartilage. The first type is a primary, also known as a synchondrosis. Now, a primary or a synchondrosis type of cartilaginous joint is going to be joined by hyaline cartilage. Now, this is in most of these long bones of the body a plate of hyaline cartilage, which is actually the location of the growth plates. So I've drawn here on top of the bone a depiction of where the growth plate would be found if we were to cut inside of that long bone. Now, the growth plate itself is made of hyaline cartilage, and it's located between the epiphysis and the diaphysis of the long bones. So we're going to find a growth plate both proximally, and we would actually find another one distally at each of these different long bones throughout the body. And typically what we're going to see is that these growth plates are going to be more distinct and pronounced early on in life. And then as we age and we get older, these pieces of cartilage are actually going to be replaced by bone. And that's what's going to determine the length of the bone itself. So the actual pieces of cartilage are going to gradually be replaced by bone as the bones lengthen and extend from the central shaft of the diaphysis out towards the distal ends or the epiphyses, both distally and proximally. So as we age, these diaphysis or the diaphysis of each bone is going to get longer and it's going to start to separate where the two growth plates are. But at some point that process is going to end and the growth plates are going to gradually be replaced by bone, and that's what's going to determine the overall length of that actual long bone in the body, which then affects the overall height of our entire skeleton. So these growth plates are made of cartilage, and that is what's going to form these primary or synchondrotic joints. Now, the second type of a cartilaginous joint is known as a symphysis. And a symphysis is going to be located between bones, and it's going to actually have a fibrocartilage pad. And this is going to allow limited amounts of movement, but offers a high amount of stability. So we can see here at the pubic region that there is a specific point of attachment between the right and the left pubic bones, and that is going to be across this fibrocartilage pad known as the pubic symphysis. So this is the symphysis type that we find at the pubis. The other type of a secondary cartilaginous joint is going to be at the intervertebral discs. And what we're going to see here is that the vertebrae are going to be attached to one another by these fibrocartilage pads known as intervertebral discs. And there's going to be two components to each disc, which we'll talk about later. But you can see here that the periphery of each pad is going to be made up of this tough, dense connective tissue known as fibrocartilage, while the inner aspect of this is going to be made up of a more gelatin-like structure, the nucleus pulposus, and that's what's going to offer the shock-absorbing capacity of these discs. But the actual connection that offers the strength and the limited mobility here in the vertebral region is going to be those fibrocartilage pads, known as the intervertebral discs. Synovial joints. Synovial joints are the most common type of joint in our body, and in most cases are what we think of when we hear the word joint. So you instinctively may think of your shoulder or the elbow, the wrist, the hip, or the knee, or some other part of your body. And that's really what's going to be a synovial joint. So they're very abundant, and it's got a lot of characteristics that we're going to go over in more detail later on. But for right now, I want to get across the concept that this type of joint, a synovial joint, is going to be freely mobile, and it's also going to be called diarthrotic. So di is going to be multiple, and arthros means joint. So this is a joint that can move in multiple directions, and it's going to be very mobile and or freely mobile, quote unquote, as it's able to move in a large variety of different types of motions. Now, a general characteristic that I want to discuss when we talk about synovial or diarthrotic joints is this concept that as a joint becomes more mobile, it is going to be less stable. So let's compare our shoulder to the hip. The hip is going to be a perfect example of a less mobile joint that offers more stability. So this is going to be an inverse relationship. As we start to gain mobility, we're going to lose stability. Or you could think of it as we become less mobile, it's going to become more and more stable. So let's look at the shoulder first. And what we're going to see if we activate one of these muscles and turn on its motion, we're going to see the action of AB or abduction. And you can see the wide range of motion that our upper limb offers here at the shoulder joint. We're able to have the upper limb positioned down by the side of our body, all the way out, and then above our heads. And this is going to be a great example of a highly mobile joint, but one that is often quite unstable. Now, you may know somebody, or you may have experienced this yourself, of a shoulder dislocation, and they're fairly common. Now, the reason why is as we look at this, it's a type of joint known as a ball and socket joint. And here we see that the ball is much, much larger than its accompanying socket. And what this means is we're going to have a high degree of movement offered at this joint, but it's also going to be quite unstable because it allows for so much mobility. Now that's going to be different than what we're going to see here at the hip. And if we were going to AB or abduct the hip, what we would see is a far more restricted range of motion. Now, obviously, some individuals are incredibly flexible and they might be able to continue to raise that lower limb quite far. But this shows this example quite well, that this is a far more stable joint, but it's also far more immobile. We can see that the head of the femur is going to be the ball of this ball and socket joint, and it's going to fit in a cup in the hip. And this is going to form a very tight connection, and it's going to be very, very strong, which is good because it's going to allow for weight transfer from our lower limb up to the vertebral column. Now, the difference in these is we have different desires of being a bipedal creature, of walking around, but also being able to move our hands in a wide variety of orientations. So the way that these joints have developed is going to give you an idea of their function. But just remember that concept of more mobility, which is less stability, and less mobility, which equals more stability, for overall concepts of synovial or diarthrotic joints. There are 5 common characteristics to all synovial joints throughout the body. The first is going to be the presence of articular cartilage. Now, articular cartilage is going to line the ends of the bones where they meet with one another, and this is going to overlay the articular surfaces of these bones. So if we were to take a look at any of these types of joints, we're going to see the presence of these articular surfaces that are going to be lined by this thin glass-like layer of hyaline cartilage. And this is going to be there to help reduce the friction where the ends of the bones meet one another. So that's going to be the first common characteristic of all of these types of joints, is the presence of this articular cartilage. Now the second, we're going to need to turn back on some of the surrounding structures. And we can see that there's going to be a fibrous or articular capsule that is going to connect from one bone to the other. And the important thing here is that this fibrous or articular capsule needs to surround the areas where the articular cartilage were. So it's going to arch from, in this case, the scapula to the humerus, and that's going to pass over the areas where the articular cartilage overlaid those articulating surfaces. So this is going to be a layer of connective tissue that is going to be connecting from each bone involved at that joint. Now, deep to this layer, we're going to see the third component of these types of joints, and that is going to be the synovial membrane. So if we were to hide this layer of the articular capsule, we can see that deep to it is going to be another layer that lines the inner aspect of that fibrous capsule, and that's going to be the actual synovial membrane. Now, the synovial membrane in some cases is also going to wrap around the surrounding tendons, or tendons that will pass through the actual joint capsule, like we see here in the shoulder. But the synovial membrane is going to line the inner aspect of that capsule, and it's going to be made up of the soft tissue that is going to surround the inner aspect of the joint. Now, if we were to take a look inside of that actual membrane, we could cut a window and take a look inside of this space. And what we're going to see is there's a cavity or an area inside the joint that is going to be between the areas of the articular cartilage and the surrounding synovial membrane. And this is going to be the joint cavity. So the joint cavity is going to be that space inside the joint which allows the movement and mobility to occur. Now, in order to reduce the friction that we see inside of these potential areas, we've already lined it with cartilage, we have a membrane on the outside, but the last thing that we're going to do is add a layer of synovial fluid. And this fluid is going to be secreted by the synovial membrane, and it's going to fill inside of that joint space. And the synovial fluid is going to further limit the friction inside of that joint. Now, that's its primary role, is to reduce friction. It's also going to act as a shock absorber and a means of delivering oxygen or nutrients to the surrounding cartilage. And it even actually helps to remove some of the waste products from the cartilage itself in that joint. So there's going to be a lot of different characteristics to these joints. So remember that there are these 5 different components. First, there is the presence of the articular cartilage. Second, the fibrous or articular capsule. Third, the synovial membrane itself. Fourth, the joint cavity. And finally, the synovial fluid within that joint cavity space. Synovial or diarthrotic joints are going to be named according to their basis of movement. And there are going to be 6 different types of diarthrotic or synovial joints. The first is a hinge joint. Now, a hinge joint is going to allow for movement in one plane. And this is what we're going to see at the elbow or at the ankle or even in a modified version at the knee. But this is only going to allow for movement within that one plane to either flex or extend. The second type of synovial joint is going to be at the base of the skull, and this is what we're going to see as a pivot joint. Now, a pivot joint is going to be different than a hinge joint, and it's going to allow for movement around a single axis. And what we can see here is that there's going to be a lot of muscles that allow for rotational movement of the head around the cervical vertebrae. And this is going to be occurring along one primary axis. And unless somebody has curvature to their spine, this is going to be along the median or mid-sagittal plane. The third type of synovial joint is going to be found in a very specific location, and it's going to be here at the base of the thumb. And this is known as a saddle joint. Now, a saddle joint is going to allow for movement in 2 different planes. So one of the planes is going to be along the axis of the bones, following the path of the tendons as they would flex and extend this joint. The other is going to be along the axis or the plane for adduction and abduction. So this is going to offer movement along the plane in the opposite direction. So these would be moving perpendicular to the opposite action of flexion and extension. So that is going to be a saddle joint, and it is located here at the carpometacarpal joint of the thumb. Now, the next type of joint is quite similar. However, a saddle joint is going to move in 2 planes, while a condyloid joint is going to move actually in 2 axes, or bidirectional movement along those 2 axis points. So here what we can see is the metacarpophalangeal joints are going to allow for a different type of movement, where we can either abduct or adduct and abduct our digits, either closer to or away from the midline along a central axis point of rotation, or we could actually flex and extend these same digits. Now, what you can see here is there's going to be pivot points or axis of rotation for this movement. And that's different than what we saw with the plane type of movement at the saddle joint. Now, the next type of movement is going to be a planar type of joint or a plane joint. And here we can see this is a good example of a synovial joint at the acromioclavicular joint. So where our acromion of the scapula meets up with the clavicle. And this is going to allow for a gliding type of motion at that joint. So as we elevate or do a shoulder shrug, we can see that these bones are going to slide past one another in a nice smooth type of motion known as a gliding type of interaction. So plane joints are going to be found here at the AC joint. They're also going to be found between the different bones of the vertebra as we lean to one side or the other, and between the ribs and the sternum. Now, the last type of joint is a ball and socket joint. And this is going to be the most dynamic type of joint, which allows for the most mobility and types of movement. And it's going to be able to move in many different axes around a common center. So where the head of that ball is going to meet within the socket is going to be the point of rotation. And this could either be an abduction and adduction type of movement, or it could be a rotational type of movement, but it's still going to occur along that central axis point in the middle of that joint. Factors of joint mobility. We are now going to take a closer look at the factors which will affect how a joint is able to move. And the direction that a joint can move is primarily determined by the actual shape of the bones. In particular, the shape of the bones at their articulating surfaces. Now, an articular surface is the fancy word for where the bones actually meet. And if you were to select the ends of each bone where they come in contact one with another, you can see what the different names of these pieces of bone are. And this is going to be derived from the Latin term articulus, which means point of contact. So the joint is going to be determined, or its movement is going to be determined by the shape of these bones at those points of articulation or points of contact. Now, if we wanted to watch this movement in action and see how the joints are actually going to move, you can select to add the muscles in the region. And if I were to add enough muscles till I get to the muscles involved with elbow flexion, I can select one of these muscles, in this case the brachialis, and then watch its motion. If I select the motion and then select elbow flexion, I see that the bones are going to move appropriately. The muscle contracts and the bones result in movement. Now, the actual path that this movement is going to occur on is based on the shape of those articulating surfaces. And what we see is that that's really going to determine the extent not only of how the bone moves, but how much it can move. So we're going to see that the range of motion is going to be the extent that we can have the bones move from one end of the movement process all the way to the other. So this is the range of motion. The path is what was determined by the actual shape of the bone. Now, the actual range of motion is not only going to be affected by the shape of the bone and the distance that can travel along that path, but it's also going to be affected by the other surrounding structures. Now, we've already mentioned the important role that connective tissue is going to play in joint movement and classification. Additionally, the muscles themselves are going to affect how much a joint can move. But there are also other factors in the area, like the other layers of connective tissue or fascia, as well as the fat and the skin over that particular joint. So if we were to use the Discover tool, we could see that we actually have an ability to kind of look deep to the skin and see what the underlying structures are. And what we're going to see is that there's a lot of different structures that are going to be running within this space. I could similarly turn on the arteries, the veins, lymphatics, or even the nerves within this region. And we get a better idea that this is a highly complicated area surrounding that joint. Now, if I have more structures that are going to be within the space that the range of motion would have occurred, we're going to start to limit movement. Now, what I mean by that is if something starts to occupy that space, what would that be? There's two dominant things. First, the muscles themselves could become so large that they start to extend out into the path where the motion would have occurred, and this would limit the movement. Now, a good example of this is a bodybuilder. Somebody that gets so big that their muscles are starting to occupy space that they previously didn't. And you can see that they're going to have a limited range of motion as a result. The other large factor that you would see would be the amount of subcutaneous tissue within a region, and this tissue is going to vary in every individual. Now, if somebody has more fat, they're highly obese, they're going to have a more limited range of motion, again, because the fat starts to extend out into the area that normally the joint would have moved within. So it's now obstructed along its path, and it can no longer follow the same trajectory that it used to in, for example, a thinner individual. Hello, my name is Dr. Alan Denton, and in this lecture I will be going over the bones of the lower limb. By the end of this lecture, you will be able to identify the bones of the thigh, leg, ankle, and foot. List and define the major articular and non-articular bone markings of each bone of the lower limb. Be able to distinguish if a bone is from the right or left sides of the lower limb. And properly use directional terminology to describe the location of the bones within the lower limb. Osteology of the lower limb. The bones of the lower limb have three primary functions. They are going to assist and support locomotion, or our ability to voluntarily move around in a bipedal fashion. They are also going to be designed to help support the weight of the body, and lastly, maintain balance of the body. Now, to facilitate these three roles, there are certain bones that are going to have different functions and have a larger or smaller role in one of those three primary functions of the bones of the lower limb. Now, as we will take a closer look at locomotion in a little bit more detail when we talk about the joints, I want to focus more on the other two functions right now, which is to support the body weight and maintain balance. Now, if we were to take a look at the axial skeleton from an anterior perspective, we could see that that axial skeleton is primarily found within the midline of the body. Now, the center of gravity for the body is going to follow this midline or mid-sagittal plane directly along that axial skeleton inferiorly. So the weight, even though it is distributed throughout the torso or the upper limbs differently, it's eventually going to come back towards that axial skeleton and be supported inferiorly by the lumbar vertebrae. Now, as we can see, the bones of the lower limb are not located in the midline of the body. Therefore, there's going to be a weight transfer that occurs from the midline out laterally away from the median or mid-sagittal plane. And where this is going to occur initially is going to be at a joint known as the sacroiliac joint. And we'll take a closer look at that with the pelvis. But the basic idea is that the weight is going to be transferring from the axial skeleton through the sacrum out to the hip bones bilaterally. And this is going to occur at the junction where the sacrum is going to meet up with the hip bones. Now, the weight transfer is going to continue inferiorly as we start to get into the lower limb through the hip joint. Now, the hip joint itself is going to be located between the hip bones and the femur. And this is going to be a critical weight transferring moment for the weight of our body. Because as we can see, the femur is not directed superiorly and inferiorly in a straight vertical line. It actually angles out laterally and then returns more medially to try to get the weight of the body back to the midline as much as possible. But again, we don't have any bones directly in the midline of the body. Now, the weight transfer is going to continue from the femur through the knee joint to the tibia. Now, the tibia is going to be the weight-bearing bone of the leg. And the leg, despite having two bones, the fibula and the tibia, the only one that really bears any weight is going to be the tibia. So we can see direct contact from the femur down to the tibia, and then that weight would continue carried down through the tibia inferiorly towards the ankle joint. Now, the ankle joint is where the weight transfer is going to occur from the tibia to the bones in the foot. And this is primarily going to occur in a bone known as the talus. And the talus is basically like the keystone of the arch of our foot. So, it's going to effectively assist in transferring the weight posteriorly to the calcaneus and then anteriorly through the other metatarsals towards the phalanges in our toes. And what this does is it evenly distributes the weight balance of our entire body evenly throughout the foot. The femur is the largest, the longest, and the heaviest bone in the entire human skeleton. And this bone plays a key role in helping with locomotion by providing large sites of muscle attachment for some of the large gluteal muscles. It's also designed to really effectively distribute the weight throughout the body and help us with balance. Now, the key characteristics that will help us identify is this a right or a left femur are going to just be mirror images of one another. So as I describe structures on the medial side of the bone or the lateral side of the bone, just remember this would be mirrored on the opposite lower limb. So in this case, we're looking at a right femur. Now, perhaps the most distinguishing characteristic of this bone is what we see here, the head of the femur. Now, the head of the femur is going to be directed medially, and it will meet up with the hip bones. Now, as we can see, the surface of the head of the femur is going to be covered with articular cartilage, which is where it meets up with the acetabulum of the hip. Now, on the medial side of the head of the femur, there is a small depression, or a pit, and this is known as the fovea capitis. So again, that will help you with orientation, and that will be directed medially. Now, moving away from the head, if we came inferolaterally, what we're going to find is the next structure is the neck of the femur. Now, the neck is going to be designed in such a way that it can help distribute the weight from the head of the femur and the body supported by that part of this bone down into the shaft or the central portion of this bone. Now, like all long bones, it's going to have this central diaphysis or shaft, with the two ends being more pronounced or robust in appearance. Now, as you can see, there's a difference between the anterior surface of the femur and the posterior surface of the femur. Along the posterior aspect of this bone, we see a delineation known as the linea aspera, and you can even see that this will divide inferiorly. So now we're going to take a closer look at some of the features proximally and distally. So the proximal end of the bone, we can see not only has the head directed medially, but it's going to have some large structures both laterally and posteriorly. And these are going to be known as trochanters. And these are large extensions of bone that are going to be for muscle attachment. Now you can see that the greater trochanter is more laterally positioned and even has a small extension aiming medially back towards the head of the femur. The lesser trochanter is more inferior and more posteriorly directed, and it's often more pyramidal in shape. Now you can see that there's a crest or a ridge of bone between the two trochanters, and that is known as the intertrochanteric crest. So these are going to be sites of muscle attachment of the muscles coming from the gluteal region. Now at the distal end of the bone, what we're going to see is the linea aspera splits. and it's going to have a portion go to both the medial side of the bone and the lateral side of the bone. And this is going to get into an area known as the epicondyles. Epi means on top of, and it will be sitting above the condyle. Now, the condyles are going to be these smooth, kind of elongated projections of bone that are positioned inferiorly. And these would sit on top of the tibia. Now, you can see that there is a depression between the two condyles. Both on the medial side, we see the medial condyle and the lateral condyle, and we see this depression that will carry all the way from an anterior and inferior perspective to even the more posterior aspect of the bone. And this is known as the intercondylar fossa. And as we look at the shape of the tibia and the tibial plateau, you'll see that there is a piece of bone that projects up into this fossa. So there are a lot of unique characteristics of both the proximal and distal femur that you will need to be able to recognize and identify on this bone in isolation. Unlike the thigh, which only had one bone, the leg actually has two long bones. The more medially oriented tibia on the medial aspect of the leg, and the more laterally oriented fibula. Now, the tibia is going to be the larger of the two bones, and as we look at it more superiorly, we see that this is the only bone of these two that is going to meet at the knee. Now, you may recall that the femur was going to sit on top of the tibia. So it is going to transfer the weight from the knee down through this large bone of the leg directly to the bones at our ankle. Now, the fibula does extend inferiorly and meets up at the ankle with the tibia, and it will provide support laterally at that joint. But at the knee, recall that the only bone articulating of these two with the femur is the tibia. So recall that the tibia is medially oriented and the fibula is laterally oriented. Now, as we look at these two bones superiorly, what we're going to see is that the tibia is going to have two projections of bone known as condyles. And there's a medial condyle and a lateral condyle of the tibia. And you may recall that the femur actually had condyles as well. And where the two condyles meet, this is where the bones articulate to create movement. Now, between the two tibial condyles, we have an extension of bone, known as the intercondylar eminence. Now, if I were to bring back the femur, you would see that it would have a small depression in between its condyles. And remember that this intercondylar eminence from the tibia is going to fit in the intercondylar fossa of the femur. And this is going to be important for the ligaments of the knee, which we will take a closer look later on. Now, the distal end of these bones is going to be a difference in appearance. And what we're going to see is that the tibia is going to have a medial extension of bone known as the medial malleolus, while the fibula is going to have a lateral malleolus. And these two projections of bone are meant to reinforce and strengthen the ankle. But you can see that there is a small depression in the distal end of the tibia that meets up with the fibula. And what we're going to see is that there's an attachment between these two bones inferiorly or distally, as well as proximally or superiorly. Now, at the proximal attachments between these two bones, this is the portion of the fibula known as the head of the fibula. And it's going to be more round in appearance, and it will fit really tight up against the inferior aspect of the lateral condyle of the tibia. Now, the distal end of the fibula is typically going to be more arrow-shaped in appearance or more diamond-shaped. So it'll be important with the fibula to recognize the difference in that appearance of both the proximal end for the head of the fibula as well as the distal end at the lateral malleolus. Now, the last landmarks I want to identify to help you orient yourself when you're looking at a tibia in isolation is the large bump or projection of bone anteriorly and proximally. This is known as the tibial tuberosity, and it's actually going to be the attachment site of the patellar ligament or patellar tendon. So therefore, when the quadriceps contract, it's able to pull through the patella down to the tibia to cause extension of the knee. And you'll see that the tibial tuberosity is going to be sitting above or positioned superior to this sharp ridge of bone on the front of the tibia. And that's known as the tibial crest. And that is going to be where you've often probably hit your shin against something and it hurts really bad because there's actually very little between the skin and the bone itself. So hopefully you're able to orient yourself through identification of the malleoli as well as the tibial plateaus and the tibial tuberosity. There are 7 tarsal bones in the posterior aspect of the foot, and these bones play a key role in distributing the weight from the rest of our body down through the lower limb and evenly distributing that through our foot. They do this by creating a longitudinal arch that connects through the metatarsals to the balls of our feet or towards our toes to help carry that weight back towards our heel. And what we can see if we were to basically look at this from a medial view is that the apex of this arch is the bone known as the talus. So we could think of this as kind of the keystone or the key bone that is responsible for maintaining and supporting that arch and transferring the weight down from the tibia into the rest of the foot. So the first bone that we're going to look at is the talus. So as I mentioned, this is the most superior of all of the tarsal bones, and it's the bone that directly meets up with or articulates with the bones at the ankle, mainly the tibia and the fibula. Now you may notice that this is a nice square-shaped appearance where these bones meet up, and the tibia is going to have an extension that reinforces this joint medially, known as the medial malleolus, while the fibula reinforces this joint laterally at the lateral malleolus. And this is truly our ankle, which allows for both dorsiflexion and plantar flexion of the foot. Now, our foot is also capable of additional movements, and those movements are going to occur in a different position known as the subtalar joint. And this is one of the joints in our foot that is going to allow for rotational types of movement, otherwise known as inversion and eversion. And what we can see is that the talus is going to actually meet up with 2 bones. Anteriorly, it meets up with a small boat-shaped bone known as the navicular. And you may recall that this sounds something like navy, which means ship in Latin. And thus the navicular has this nice, smooth, kind of canoe or boat-shaped appearance, and it's located anterior to the talus. If we were to go inferior to the talus, this would be the location of the large heel bone, known as the calcaneus. And recall that the calcaneal tendon from the posterior calf, also referred to as the Achilles, comes down and attaches to the calcaneus. So you can imagine that weight distribution is going to come inferiorly and posteriorly through the talus down into the calcaneus, or it could come anteriorly through the talus towards the navicular bone. Now, the navicular bone is going to be positioned on the medial aspect of the foot, and we can see that anteriorly it meets up with 3 more of the tarsal bones, and these are known as the cuneiforms. We have a medial cuneiform, an intermediate cuneiform, and a lateral cuneiform. Now, note that those references of medial and lateral are related back to the midline of the body. And even though this is not the most lateral bone in the foot, it is more lateral than the other 2 cuneiforms. And we can see that each cuneiform is going to meet up with its own individual metatarsal. And there is some amount of overlap between these bones where they meet. However, it's more or less a 1-to-1 ratio between these first 3 digits and the 3 cuneiforms. The last of the tarsal bones is the cuboid, and this is the square-shaped bone on the lateral aspect of our foot that meets up with the 4th and the 5th metatarsals. Note that posteriorly the cuboid is also going to be articulating with the calcaneus. So the 7 tarsal bones are designed to help distribute the weight from the rest of our body, and they each have a unique position and orientation that will just be a matter of repetition to understand until you can relate these back to their anatomical position. In addition to the 7 tarsal bones in our foot, more at the heel or articulating at the ankle, we also have 14 additional phalanges, or the small bones in our digits, as well as 5 metatarsals. Now, the metatarsals are going to be numbered beginning medially and working laterally. And the first metatarsal is going to meet up with the bones of the big toe. Now, we would continue progressing laterally with the second metatarsal, the third, the fourth, and ending with the 5th. So the 5th metatarsal is going to be with our small digit, or otherwise known as the pinky, and this would be on the lateral aspect of our foot. And you'll see that there's a difference in appearance of this 5th metatarsal compared to the other metatarsals. And that extension on the lateral aspect of this bone is for muscle attachments from the lateral aspect of our leg. Now, the metatarsals are going to meet up with the phalanges. And what we're going to see is that 4 of the digits, beginning with our 2nd on out through the 5th, are each going to have 3 bones. We have a proximal phalanx, a middle phalanx, and a distal phalanx, meaning that we're going to have articulations between these bones at multiple points. Now, the great toe, or the big toe, otherwise known as the hallux, is going to only have 2 phalanges. So we will have a distal phalanx and a proximal phalanx. Now, what we're going to see as we look at the joints in the foot is that these are going to have specific names. So where the metatarsals meet up with the phalanges is the metatarsophalangeal joint. In the digit itself, between the proximal phalanx and the middle phalanx, this is going to be the proximal interphalangeal joint, while between the middle and distal phalanx will be the distal interphalangeal joint. Now, as you may notice, the hallux, or the great toe, only has 1 joint in between its phalanges, so this is known as the interphalangeal joint. So keep in mind the different joints that will help you remember the movements at these positions in the foot, as well as the different bones that will be found between them in the toes. So recall that there are only 14 phalanges because the great toe does not have a middle phalanx. Also, beginning medially, working laterally is how we number not only the toes, but the metatarsals, beginning with number 1 medially and ending with number 5 laterally. Hello, my name is Dr. Alan Detton, and in this lecture I will be going over the special areas of the lower limb. At the end of this lecture, you will be able to identify the boundaries of the femoral triangle, the adductor canal, and the popliteal fossa. Additionally, you will be able to identify the major contents of the femoral triangle, the adductor canal, and the popliteal fossa. Near the ankle, you will be able to identify the structures passing along the medial aspect of this region through the mnemonic known as Tom, Dick, and Harry. Lastly, you should be able to identify the surface anatomy landmarks on the anterior and posterior aspects of the lower limb. The femoral triangle is a region in the anterior thigh of a triangular zone that will help you identify many of the structures within this part of our body. And to help you remember the sequence of the structures within the femoral triangle, I like to use the simple mnemonic navel, which will help you remember the order from lateral moving medially, that the femoral nerve is the most lateral structure within the space, followed by the femoral artery, the femoral vein, and then lymphatics. So let's first take a closer look at the boundaries of this area before we look at those contents in more detail. The first thing that we're going to see is that the lateral boundary is formed by the sartorius muscle. Recall that the sartorius muscle began at the anterior superior iliac spine, the ASIS, and then coursed medially and diagonally down through our thigh. The medial boundary of the femoral triangle is going to be one of the adductor muscles, the adductor longus muscle. So we can now see the lateral boundary formed by the sartorius and the medial boundary formed by the adductor longus muscle. The base of the triangle is actually going to be the inguinal ligament. So the base is going to be directed superiorly and the apex is directed infromedially. So now we can see the inguinal ligament, adductor longus, and sartorius forming the boundaries of this space. Deep to the contents, the floor of this area is going to be made by the iliopsoas muscle laterally and the pectineus muscle medially. Recall that the iliopsoas was formed by the psoas major and iliacus as they join inferior to the inguinal ligament. So the iliopsoas will be deep to the contents laterally, while the pectineus muscle will be deep to the contents medially. The contents within the femoral triangle are best remembered, again, with that mnemonic navel. So beginning laterally, we can see the femoral nerve, then the femoral artery, and lastly, the femoral vein. The femoral nerve is typically located between the junction point of psoas major and iliacus, as the femoral nerve needed to pass deep to the psoas to get more superficially to reach the contents in the thigh. So the femoral nerve will be most lateral, the femoral artery is near the midline of the inguinal ligament, and the femoral vein is located just medial to it. One way you can help differentiate between the artery and the vein in the cadaver is to look for the presence of the great saphenous vein draining into the femoral vein more medially. Now the last content of this space is an empty space where we call the femoral canal, a small area that is going to have fat and lymphatics. The deep inguinal lymph nodes are going to be the most medial area or the most medial content within this area of the femoral triangle. So navel is going to stand for the femoral nerve, femoral artery, femoral vein, and then lymph nodes, which are predominantly the deep inguinal lymph nodes. So the lymph from our lower limb is going to enter the abdominal cavity by passing medial to the femoral vein within this space. The adductor canal is a special region within the thigh that is going to allow for the passage of the femoral artery and femoral vein infromedially down through the thigh, to then emerge posteriorly behind the knee within the popliteal fossa, as these vessels become the popliteal artery and the popliteal vein. To better visualize the canal, I've cut a window through two of the muscles within the anterior compartment of the thigh, the first of which is the sartorius muscle. The sartorius muscle is the long muscle that is going to help us flex both our hip and our knee, and this muscle courses infromedially, basically cutting diagonally and medially across our anterior thigh. This muscle is going to form the roof of the adductor canal, meaning that the structures that are going to pass within this space will lie deep to the sartorius muscle. Therefore, I needed to cut a window through this muscle to allow us to see the path of those vessels. I've also cut through the vastus medialis, one of the large quadriceps muscles that is going to be on the medial aspect of our knee. The adductor canal is going to begin at the apex of the femoral triangle. So recall that the femoral triangle was going to be the space on our anterior thigh bounded laterally by the sartorius muscle, medially by the adductor longus, and at its base by the inguinal ligament. So as the femoral artery and femoral vein pass inferiorly, and they're going to begin the path in the adductor canal at the apex of the triangle. So beginning at the apex, passing inferior and deep to the sartorius muscle, these vessels are going to continue until they pass through an opening within the adductor magnus, known as the adductor hiatus. So here we can see that the adductor magnus, a large adductor of our thigh, is going to have two different components. There's going to be the adductor portion, more superiorly and medially, and a hamstring portion that will attach more distally. These two attachments are going to create an arch, or essentially create a window that these vessels can pass through. So the adductor hiatus is going to be the boundary point for where the femoral artery and femoral vein are now going to change names. So anterior and superior to this point, they are femoral, and then as they pass through this opening of the adductor hiatus, they're now going to change names and lie posteriorly within the popliteal fossa and be referred to as the popliteal artery and popliteal vein. So the adductor canal is going to terminate at the hiatus, begin at the apex of the femoral triangle, and lie deep to the sartorius muscle. The popliteal fossa is a diamond-shaped depression on the posterior aspect of our knee. Within this area, there is a lot of fat that is going to surround and protect the contents within this space. The reason that this is a really good area to understand is that by understanding the boundaries and the contents, you can better identify many of the structures within this region of the lower limb. Let's begin by taking a closer look at the boundaries that form the popliteal fossa, beginning with the supromedial boundary, which is formed by the semimembranosus muscle. Recall that two of the hamstring muscles, the semimembranosus and the semitendinosus, both passed along the medial aspect of our knee. The semimembranosus is a large muscle inferiorly, and it's going to help reinforce the posterior aspect of our knee joint capsule, and it's going to form the medial boundary superiorly of the popliteal fossa. The supralateral boundary is going to be formed by the biceps femoris muscle. Recall that the biceps femoris had both a long head and a short head, both of which will pass across the knee joint along the lateral aspect of the knee. So the hamstring muscles, the semitendinosus, semimembranosus, and the biceps femoris long head are going to help form the supromedial and supralateral boundaries of this fossa. On the inferior aspect, we're going to have one muscle form both the medial and lateral boundaries, the gastrocnemius muscle. The medial head of the gastrocnemius forms the infromedial border of the popliteal fossa, while the gastrocnemius lateral head forms the lateral boundary. Within the popliteal fossa, we're also going to have a deep boundary, or the floor, made up by the surface of the femur along its posterior distal end. The roof would be the overlying skin and popliteal fascia of the region. Within the popliteal fossa, there are three dominant contents that are stacked up along the midline of the knee. Beginning with the most deep structure, this is the popliteal artery, So an easy way to remember this is the most important structure coming down into the lower limb, especially the leg, is going to be the artery as it carries blood to this region. Sitting superficial to the popliteal artery, we can identify the popliteal vein, which is more readily identifiable due to the presence of the small saphenous vein draining into the popliteal vein. So the artery will be the deepest of the structures within the popliteal fossa. Then as we come more superficially, the next structure we encounter is the popliteal vein. The most superficial of the contents are the nerves, the tibial nerve and the common fibular nerve. Recall that these are the two division points of the sciatic nerve. So the tibial nerve is going to be the more medial of the two branches from the sciatic nerve, and it's going to overlie the popliteal artery and vein as they enter into the leg along the midline. The common fibular nerve is going to be the more lateral division from the sciatic nerve and course laterally in close proximity to the biceps femoris muscle. To remember the order of the structures passing between the medial malleolus and the calcaneal tendon, beginning anteriorly and moving posteriorly, remember the saying, Tom, Dick, and a very nervous Harry, often simply referred to as Tom, Dick, and Harry. This is going to help you remember the names of the different structures passing within this region. So again, let's begin with identification of the medial malleolus and the calcaneal tendon. The first tendon that you can palpate crossing posterior to the medial malleolus is the tibialis posterior tendon, which is going to start our saying. So T for tibialis posterior is Tom in the mnemonic. D in the mnemonic is for flexor digitorum longus. So the next tendon that we're going to see passing behind the medial malleolus is the flexor digitorum longus tendon. The last muscle tendon that we see passing through this space is going to be for Harry. Now Harry is going to be the flexor hallucis longus muscle. And the flexor hallucis longus muscle is going to be the deepest of these three tendons. So often we refer to Harry as being very nervous because he tends to hide. It's a large, big muscle in the posterior leg, but here we just see the deep tendon emerging behind or deep to the calcaneal tendon. So the order of the tendons is TDH for Tom, Dick, and Harry, with tibialis posterior, flexor digitorum longus, and flexor hallucis longus. The other structures that are passing through this space can be remembered by the simple addition of a very nervous Harry. And this will help us remember the artery, vein, and nerve passing within this same space. The artery is the posterior tibial artery. And the posterior tibial artery will be sandwiched by the two deep paralleling posterior tibial veins. So the artery and the veins are going to be located more anterior or closer to the medial malleolus than the tibial nerve. The tibial nerve is going to run by itself and then split into the medial and lateral plantar nerves. So remember that the arteries and the veins are going to have posterior tibial in their name, whereas the nerve is simply the tibial nerve. So Tom, Dick, and a very nervous Harry are going to be all of the structures, again passing between the medial malleolus and the calcaneal tendon on the medial aspect of our foot.
Hello, Dr. Yasmin Carter here, Assistant Professor of Anatomy at the University of Massachusetts Medical School. And in this recording series, we're going to be discussing the joints of the lower limb. These bony wonders of biomechanics are what allow us to stand and walk and dance. Some of us a little better than others, I admit. Recall here that anatomists don't call this whole area the leg. Only the portion between the knee and the ankle is what we call the leg. So ensure you say lower limb, not leg. The joints of the lower limb include some of the articulations of the pelvic girdle, specifically the sacroiliac joints, seen here, and the pubic symphysis, seen here. The remaining joints of the lower limb are the hip joints, here, the knee joint, here, the tibiofibular joints, the ankle joints, and foot joints. So join me now as we learn more about the wonderful joints of the lower limb. Hello, Dr. Carter here. In this recording, we're going to be discussing the joints of the pelvic girdle, specifically the pubic symphysis and sacroiliac joint. Let's start by reorienting ourselves to the bones of the pelvic girdle. First, we have the hip bone, or os coxae, with its ilium, and a pubis region, which is divided into a superior pubic ramus and an inferior pubic ramus. Posteriorly, we have the sacrum here. The sacrum has wings, or alar. Now, the pubic region of the bones meet in the middle at the pubic symphysis, which is a secondary cartilaginous joint consisting of a fibrocartilaginous interpubic disc and some surrounding ligaments. In general, this space is wider in females. And importantly, the bone surfaces are not flat, but are actually quite roughened, which can be seen if we remove the interpubic disc. The crests and valleys of the bone surface increase with age. Only slight movements of the pubic symphysis are possible, and most movement occurs in females during late gestation and childbirth, and occasionally this movement can be quite considerable, which is just ouch. The sacroiliac joints link the axial skeleton, which at this level is mostly the vertebral column and the entire lower body. The sacroiliac joint, therefore, is one of the most stable joints in the body, and definitely one of the strongest, as it has to hold the weight of the entire upper body. Pulling back out now, we can see that anteriorly a synovial joint exists between the ear-shaped auricular surfaces of the sacrum and the ilium. So let's look at those now by isolating our ilium here. And we can see this ear-shaped might be a bit of a bold term, but let's go with it, ear-shaped area. This is covered in cartilage. And we have a matching surface on the alar of our sacrum, which we can see if we return to our sacrum and we look here. These auricular surfaces are much like the pubic symphyses in that they're highly irregular, and the roughened areas essentially lock into one another, allowing for very little movement, unlike most synovial joints. And this is really a consequence of their role in transmitting the majority of the weight of the body to the hip bones. They essentially lock the pelvis in place. Abundant sacroiliac ligaments, which you don't need to know at your level, are primarily involved in transferring the weight of the upper body from the axial skeleton to the two ilia of the appendicular skeleton. In the next recording, we will look at how that weight travels further down the leg through the hip bone. Hello, Dr. Carter here again. In the last recording, we looked at the joints of the pelvic girdle connecting the axial and inferior appendicular skeleton. Now we'll be examining the hip joint. In order to better visualize the hip joint, we have removed the anterior portion of the pelvis. The hip joint is the bony connection between the pelvic girdle and the lower limbs. It's a ball and socket type of synovial joint, where the head of the femur is the ball and the cup-shaped acetabulum is the accepting socket. Well, cup shape might be overstating it a little bit. It's more like a cupped hand, inasmuch that it has a lot less surface area than you might expect. This arrangement allows for a multi-axial range of movement, and in fact it's the second most mobile joint in the human body, next to the glenohumeral joint that we saw in the shoulder. And boy, is it strong! As we learned in the previous recording, when standing, the entire weight of the upper body is transmitted through the pelvic girdle to the femora. The head of the femur is essentially spherical, which we can see better when it's in isolation. The head of the femur is covered with articular cartilage. Much like the shoulder and its glenohumeral joint, a lip or acetabular labrum surrounds the acetabular margin, creating a fibrocartilaginous rim. And this is very important because it can actually increase the surface area of the acetabulum by about 10%. The hip joints themselves are enclosed within strong joint capsules, which have two layers, a loose external fibrous layer, sometimes called the fibrous capsule, and an inner synovial membrane. The loose fibrous layer is then surrounded by the ligaments of the hip. During extension, all of these layers wind up, essentially spiraling and becoming increasingly tight, restricting extension. But flexion increasingly unwinds and loosens these layers. This allows for considerably more flexion than extension of the hip joint, and concurrently increasing mobility. This is a very key concept. We can see this really well if we add our muscles back on. If we look first at gluteus maximus, one of the major motions is hip extension, and we can see that we are seeing relatively little possible extension. But if we then swap to our psoas muscle, the major motion of which is hip flexion, we can see that a large range of flexion is possible. Now, beyond flexion and extension, the hip movements include abduction and adduction, as well as medial and lateral rotation, and circumduction. Circumduction is just a combination of all of these. The degree of flexion and extension possible is restricted by the position of the knee. As we can see here, if the knee is flexed, then the hamstrings are relaxed, and the hip can be significantly actively flexed. It can also go further without strain through passive flexion, meaning if you grab it and pull it up. However, extension is still fairly limited. And that's the end of the hip joint. Hello, Dr. Carter here. In the last recording, we looked at the first joint of the lower limb proper, the hip joint. Now we will be discussing the knee joint. The knee is the largest joint in the human body, and it's also the most superficial. You can palpate almost the whole thing. The knee is a synovial joint, and it acts like a hinge, allowing the joint to move almost exclusively in flexion and extension. But the knee can make some other relatively small medial and lateral rotations, seen here. These are best seen when the knee is bent. Let's return now to our bones. For such an important joint, allowing us to walk and sit and stand, it is surprisingly weak, and this is in part due to the wide range of permitted flexion, and partly because of the inherent instability of having curved surfaces of the femoral condyles sitting on the flat tibia. The knee joint is kept stable by the ligaments and tendons which attach the femur to the tibia and by the muscles surrounding it. Although actually relatively little muscle mass is part of the knee, these provide the majority of the support. The straight or erect knee position, extended here as we see it, is the most stable position of the knee joint. Think of standing. You don't tend to wobble. The knee is basically locked. Externally, the joint capsule is strengthened and supported by three major ligaments: the patellar tendon, the medial collateral ligament, and the lateral collateral ligament. On a side note, the synovial patellofemoral joint is considered part of the knee, but we're focusing more on the basics here. The patellar ligament is the continuation of the quadriceps femoris tendon, and it's the most anterior ligament of the knee joint. When the knee is erect, the two collateral ligaments are tensed, providing strong support to the joint. As the knee bends, they loosen and release, and this is what allows for the small amount of medial and lateral rotation I mentioned earlier when the knee is bent. So the two collateral ligaments are first the more rope-like lateral collateral ligament. This is also known as the fibular collateral ligament, obviously because it sits on the lateral side and it runs from the femur at the lateral epicondyle to the fibula, hence its other name. This is a really important key concept here. Although this ligament attaches here, the fibula itself is not considered a bone of the knee joint. The second ligament is the medial collateral ligament, also known as the tibial collateral ligament. Now, unlike its counterpart, it's really flat and more like a band, and it runs from the medial epicondyle of the femur to the tibia. Inside of the joint capsule, we have the cruciate ligaments and the menisci. Remember, cruciate is Latin for cross, and that's exactly what the cruciate ligaments do. They cross each other within the joint capsule, but outside of the synovial cavity. This is best seen from above, as we're looking here. When the knee is bent or flexed, as I mentioned, the collateral ligaments become slack, so it's the cruciate ligaments that are vital for holding the femoral and tibial articular surfaces together. A key concept here is that the cruciate ligaments are named for where they originate on the tibial plateau. Therefore, the anterior cruciate ligament, commonly known as the ACL, arises from the tibia at the anterior intercondylar area, seen here. Whereas the posterior cruciate ligament, or PCL, arises from the posterior intercondylar area. The articular surface of the tibia are two crescent-shaped plates of fibrocartilage, the medial and lateral menisci, and these partly act as shock absorbers. And that's it. That's the knee. Hello, Dr. Carter here again. In the last recording, we discussed the knee joint. Now, we'll be talking about the ankle and subtalar joints. The tibia and fibula are held together at their shafts by the interosseous membrane, but the two bones are mostly connected here at what's called the tibiofibular joint. This is a syndesmosis, or a plane type of synovial joint, held together by the tibiofibular ligament. Very little movement takes place here. So let's move to the ankle joint proper. The ankle joint can be approximated by looking at the prominences of the medial and lateral malleolus with the skin on, which approximate the line of the ankle joint right here. On yourself, the ankle joint can be felt on the front of your ankle as a slight depression between the tendons. The ankle joint, or more properly the talocrural joint, is a hinge type of synovial joint involving the distal tibia, the fibula, and the talus. The distal ends of the tibia and fibula form what's known as the malleolar mortise. A mortise is just a recess into which something fits, like a jigsaw puzzle. And that something is the rounded superior articular surface of the talus, which is called the trochlea. The trochlea is more narrow posteriorly, and so it's not gripped as well by the joint. And because of this, during plantar flexion, the ankle joint is relatively unstable, and this is when most of the ankle injuries occur. You can see how much smaller it is back here. Of course, ligaments are vital to the ankle's stability. The lateral ligament of the ankle is actually made up of 3 discrete ligaments. But it's okay, at your level you don't need to know the names of these. Medially, we have the large deltoid ligament, also known as the medial collateral ligament, and it attaches to the medial malleolus. During eversion, the deltoid ligament stabilizes the ankle joint and prevents dislocation. Let's add some muscles on here and have a look at these movements. The primary movements of the ankle are dorsiflexion and plantar flexion. We can see that here in the motion of tibialis anterior, which is dorsiflexion, and in the motion of soleus, which is plantar flexion. Of course, it's far more dynamic than this, because think about drawing a circle with your big toe. But let's stick with the basics for now. Let's move further down now to the subtalar joints. These are the anterior and posterior articulations between the calcaneus and the talus. Together they form a functional unit termed the talocalcaneal or subtalar joint. It's a single synovial joint where the majority of inversion and eversion occurs. And we can see those here . If we look at the motion of fibularis longus, whose main motion is eversion. And again at tibialis anterior, whose other motion is inversion. And that's the joints of the ankle. Hello, Dr. Carter here again. In the last recording, we discussed the ankle and subtalar joints. Now we'll be talking about the joints of the foot. Let's start with a recap of our bones. First we have our tarsals, then our metatarsals, then our phalanges, which are organized into a proximal row, an intermediate or middle row, and a distal row. The foot joints are basically a reflection of the joints of the hand, but of course it's a far more complex structure because it's adapted to allow a bipedal stance and locomotion. And it's the only part of the body that's in regular contact with the ground. There are 28 separate bones in the human foot and 31 joints, including the ankle joint. So when I say it's complex, I mean it. What most people think of as the foot proper involves the joints of the tarsals, metatarsals, and phalanges. We've already discussed the subtalar joint. The other intertarsal joints, for example the tarsometatarsal joints and the intermetatarsal joints between them, are relatively small. These joints are tightly bound by ligaments, which allow very little movement, but this is important because they do allow some movement. If the feet were just a couple of solid bones, then every time your foot struck the ground, it would send shock waves right up your leg. So these ligaments basically act as shock absorbers, using that little bit of movement to dissipate these impacts. Additionally, the tarsal and metatarsal bones are arranged in longitudinal and transverse arches. And this increases the tolerance of the foot. These ligament-supported arches also act like springs, propelling the foot forward during walking and running, or in my case, a unique ability to fall upstairs. All this flexibility also allows the foot to deform in response to walking on uneven ground. And of course, this is helped tremendously by the more flexible metatarsophalangeal and interphalangeal joints. The tarsometatarsal joints have very little movement, as I said, and this is the articulation between the metatarsals and the tarsals. And we can understand where those are if we look with the skin back on, essentially looking at an imaginary line through the midfoot, starting at the little lump here, which is actually the base of the fifth metatarsal on the lateral side, and traveling medially. Metatarsophalangeal joints are condyloid joints. They're basically the joint between the rounded head of the metatarsals and the shallow concavities on the proximal flange, which means there's a wide range of movement that can occur here. Actively, we mostly see extension occurring, much greater than that of flexion, and this is adapted to the needs of walking. If you think about it, when you bend your foot, such as walking on tippy toes, you have a tremendous amount of active extension, but very little flexion. And we can see that if we put our muscles back on and look at our extensor digitorum, we can see where extension is occurring. The interphalangeal joints, like the phalangeal joints of the hand, are almost pure hinge joints, in which the trochlear surfaces on the phalangeal heads just attach to the next phalangeal base. And again here, we have flexion and extension, but differently, it's flexion that is marked or more obvious, and extension is limited by the tension of the flexor muscles. And again, we have a proximal interphalangeal joint, an interphalangeal joint, and a distal interphalangeal joint. And that's the joint.
My name is Dr. Alan Detton, and in this lecture I will be going over the bones of the pelvic girdle and lower limb. By the end of this lecture, you will be able to identify the bones of the pelvic girdle, the thigh, the leg, ankle, and foot. You will be able to list and define the major articular and non-articular bone markings of each bone of the lower limb. Additionally, you will be able to distinguish if a bone is from the right or left sides of the lower limb. And lastly, properly use directional terminology to describe the location of the bones within the lower limb. Osteology of the lower limb. The bones of the lower limb have three primary functions. They are going to assist and support locomotion, or our ability to voluntarily move around in a bipedal fashion. They are also going to be designed to help support the weight of the body and lastly, maintain balance of the body. Now, to facilitate these three roles, there are certain bones that are going to have different functions and have a larger or smaller role in one of those three primary functions of the bones of the lower limb. Now, as we will take a closer look at locomotion, a little bit more detail when we talk about the joints, I want to focus more on the other two functions right now, which is to support the body weight and maintain balance. Now, if we were to take a look at the axial skeleton from an anterior perspective, we could see that that axial skeleton is primarily found within the midline of the body. Now, the center of gravity for the body is going to follow this midline or mid-sagittal plane directly along that axial skeleton inferiorly. So the weight, even though it is distributed throughout the torso or the upper limbs differently, it's eventually going to come back towards that axial skeleton and be supported inferiorly by the lumbar vertebrae. Now, as we can see, the bones of the lower limb are not located in the midline of the body. Therefore, there's going to be a weight transfer that occurs from the midline out laterally away from the median or mid-sagittal plane. And where this is going to occur initially is going to be at a joint known as the sacroiliac joint. And we'll take a closer look at that with the pelvis. But the basic idea is that the weight is going to be transferring from the axial skeleton through the sacrum out to the hip bones bilaterally. And this is going to occur at the junction where the sacrum is going to meet up with the hip bones. Now, the weight transfer is going to continue inferiorly as we start to get into the lower limb through the hip joint. Now, the hip joint itself is going to be located between the hip bones and the femur. And this is going to be a critical weight transferring moment for the weight of our body. Because as we can see, the femur is not directed superiorly and inferiorly in a straight vertical line. It actually angles out laterally and then returns more medially to try to get the weight of the body back to the midline as much as possible. But again, we don't have any bones directly in the midline of the body. Now, the weight transfer is going to continue from the femur through the knee joint to the tibia. Now, the tibia is going to be the weight-bearing bone of the leg. And the leg, despite having two bones, the fibula and the tibia, the only one that really bears any weight is going to be the tibia. So we can see direct contact from the femur down to the tibia, and then that weight would continue carried down through the tibia inferiorly towards the ankle joint. Now, the ankle joint is where the weight transfer is going to occur from the tibia to the bones in the foot. And this is primarily going to occur in a bone known as the talus. And the talus is basically like the keystone of the arch of our foot. So, it's going to effectively assist in transferring the weight posteriorly to the calcaneus and then anteriorly through the other metatarsals towards the phalanges in our toes. And what this does is it evenly distributes the weight balance of our entire body evenly throughout the foot. The hip bone is a rather interesting bone because it technically is actually three bones that have fused together. Early on in development, these three pieces do not actually meet up. And until about age 20, when the bones start to fuse, they're actually still distinguishable independently. However, as an adult, these three bones are still identifiable individually, yet there is no visible point of fusion after they have joined together. The three different bones forming the hip bone are the superiorly located ilium, the anteriorly located pubis, and the inferiorly located ischium. Another interesting fact about the hip bone is it's also known as the innominate bone, which means unnamed. So technically, by giving it the name innominate, it may have actually just been named. But as it's also named the hip bone, this is just an interesting point of trivia. The point of fusion where these three bones meet up is in the cup-like depression that receives the head of the femur, known as the acetabulum. The actual Y-shaped junction of where these bones meet up and fuse is known as the triradiate cartilage. So the three spokes are going to aim between the junction of where these bones meet up. Let's now take a closer look at each of these bones individually, beginning with the ilium, the most superior of the three bones. The ilium is a broad, flat bone that extends superiorly up above the superior aspect of the acetabulum. So it does form an aspect of this cup-like depression, but the majority of the bone extends up above what we refer to as the hip joint. The portion that extends up like this fan-shaped portion or a wing is known as the ala. The inner aspect of that extension is a smooth depression known as the iliac fossa. On the medial aspect of this extension, there's a roughened area and an ear-shaped area that we call the auricular surface that meets up with the sacrum. At the superior extent of the ala, we're going to see a ridge known as the iliac crest, which can be felt or palpated in majority of individuals. If we followed the iliac crest anteriorly and slightly inferiorly, we're also going to be able to feel or palpate a large prominence anteriorly. This is known as the anterior superior iliac spine, or the ASIS. The ASIS is not only a key landmark for physicians, as it is readily palpated in almost everybody, but it is also going to be a key site of attachment for two muscles of the thigh and the inguinal ligament. Let's now take a closer look at the pubis, the most anterior of these three bones. If we were to put the hip in anatomical position, we would see that the anterior superior iliac spine is in a straight line with a portion of the pubic bone, or the pubis, known as the pubic tubercle. We see that the pubis is going to form the anterior aspect of the acetabulum, and it's also going to start to enclose a true hole through the hip, known as the obturator foramen. So this bone is going to form the superior aspect of the obturator foramen, while the inferior aspect is going to be formed by the last of the three bones, the ischium. The ischium is the posteriorly and inferiorly oriented portion of our hip. The portion that you would actually sit on is known as the ischial tuberosity, a roughened area that is for muscular attachment of the hamstrings in the back of the thigh. We can also see a spike or a spine projecting medially off of the ischium, which is known as the ischial spine. So we see that this forms the inferior aspect of the obturator foramen and the acetabulum. The femur is the largest, the longest, and the heaviest bone in the entire human skeleton. And this bone plays a key role in helping with locomotion by providing large sites of muscle attachment for some of the large gluteal muscles. It's also designed to really effectively distribute the weight throughout the body and help us with balance. Now, the key characteristics that will help us identify is this a right or a left femur are going to just be mirror images of one another. So as I describe structures on the medial side of the bone or the lateral side of the bone, just remember this would be mirrored on the opposite lower limb. So in this case, we're looking at a right femur. Now, perhaps the most distinguishing characteristic of this bone is what we see here, the head of the femur. Now, the head of the femur is going to be directed medially, and it will meet up with the hip bones. Now, as we can see, the surface of the head of the femur is going to be covered with articular cartilage, which is where it meets up with the acetabulum of the hip. Now, on the medial side of the head of the femur, there is a small depression, or a pit, and this is known as the fovea capitis. So again, that will help you with orientation, and that will be directed medially. Now, moving away from the head, if we came inferolaterally, what we're going to find is the next structure is the neck of the femur. Now, the neck is going to be designed in such a way that it can help distribute the weight from the head of the femur and the body supported by that part of this bone down into the shaft or the central portion of this bone. Now, like all long bones, it's going to have this central diaphysis or shaft, with the two ends being more pronounced or robust in appearance. Now, as you can see, there's a difference between the anterior surface of the femur and the posterior surface of the femur. Along the posterior aspect of this bone, we see a delineation known as the linea aspera, and you can even see that this will divide inferiorly. So now we're going to take a closer look at some of the features proximally and distally. So the proximal end of the bone, we can see not only has the head directed medially, but it's going to have some large structures both laterally and posteriorly. And these are going to be known as trochanters. And these are large extensions of bone that are going to be for muscle attachment. Now you can see that the greater trochanter is more laterally positioned and even has a small extension aiming medially back towards the head of the femur. The lesser trochanter is more inferior and more posteriorly directed, and it's often more pyramidal in shape. Now you can see that there's a crest or a ridge of bone between the two trochanters, and that is known as the intertrochanteric crest. So these are going to be sites of muscle attachment of the muscles coming from the gluteal region. Now at the distal end of the bone, what we're going to see is the linea aspera splits, and it's going to have a portion go to both the medial side of the bone and the lateral side of the bone. And this is going to get into an area known as the epicondyles. Epi means on top of, and it will be sitting above the condyle. Now the condyles are going to be these smooth, kind of elongated projections of bone that are positioned inferiorly, and these would sit on top of the tibia. Now you can see that there's a depression between the two condyles. Both on the medial side, we see the medial condyle and the lateral condyle, and we see this depression that will carry all the way from an anterior and inferior perspective to even the more posterior aspect of the bone. And this is known as the intercondylar fossa. And as we look at the shape of the tibia and the tibial plateau, you'll see that there is a piece of bone that projects up into this fossa. So there are a lot of unique characteristics of both the proximal and distal femur that you will need to be able to recognize and identify on this bone in isolation. Unlike the thigh, which only had one bone, the leg actually has two long bones. The more medially oriented tibia on the medial aspect of the leg, and the more laterally oriented fibula. Now, the tibia is going to be the larger of the two bones, and as we look at it more superiorly, we see that this is the only bone of these two that is going to meet at the knee. Now, you may recall that the femur was going to sit on top of the tibia. So it is going to transfer the weight from the knee down through this large bone of the leg directly to the bones at our ankle. Now, the fibula does extend inferiorly and meets up at the ankle with the tibia, and it will provide support laterally at that joint. But at the knee, recall that the only bone articulating of these two with the femur is the tibia. So recall that the tibia is medially oriented and the fibula is laterally oriented. Now, as we look at these two bones superiorly, what we're going to see is that the tibia is going to have two projections of bone known as condyles. And there's a medial condyle and a lateral condyle of the tibia. And you may recall that the femur actually had condyles as well. And where the two condyles meet, this is where the bones articulate to create movement. Now, between the two tibial condyles, we have an extension of bone known as the intercondylar eminence. Now, if I were to bring back the femur, you would see that it would have a small depression in between its condyles. And remember that this intercondylar eminence from the tibia is going to fit in the intercondylar fossa of the femur. And this is going to be important for the ligaments of the knee, which we will take a closer look later on. Now, the distal end of these bones is going to be a difference in appearance. And what we're going to see is that the tibia is going to have a medial extension of bone known as the medial malleolus, while the fibula is going to have a lateral malleolus. And these two projections of bone are meant to reinforce and strengthen the ankle. But you can see that there is a small depression in the distal end of the tibia that meets up with the fibula. And what we're going to see is that there's an attachment between these two bones inferiorly or distally, as well as proximally or superiorly. Now, at the proximal attachments between these two bones, this is the portion of the fibula known as the head of the fibula. And it's going to be more round in appearance, and it will fit really tight up against the inferior aspect of the lateral condyle of the tibia. Now, the distal end of the fibula is typically going to be more arrow-shaped in appearance or more diamond-shaped. So it'll be important with the fibula to recognize the difference in that appearance of both the proximal end for the head of the fibula as well as the distal end at the lateral malleolus. Now, the last landmarks I want to identify to help you orient yourself when you're looking at a tibia in isolation is the large bump or projection of bone anteriorly and proximally. This is known as the tibial tuberosity, and it's actually going to be the attachment site of the patellar ligament or patellar tendon. So therefore, when the quadriceps contract, it's able to pull through the patella down to the tibia to cause extension of the knee. And you'll see that the tibial tuberosity is going to be sitting above or positioned superior to this sharp ridge of bone on the front of the tibia. And that's known as the tibial crest. And that is going to be where you've often probably hit your shin against something and it hurts really bad because there's actually very little between the skin and the bone itself. So hopefully you're able to orient yourself through identification of the malleoli as well as the tibial plateaus and the tibial tuberosity. There are 7 tarsal bones in the posterior aspect of the foot, and these bones play a key role in distributing the weight from the rest of our body down through the lower limb and evenly distributing that through our foot. They do this by creating a longitudinal arch that connects through the metatarsals to the balls of our feet or towards our toes to help carry that weight back towards our heel. And what we can see if we were to basically look at this from a medial view is that the apex of this arch is the bone known as the talus. So we could think of this as kind of the keystone or the key bone that is responsible for maintaining and supporting that arch and transferring the weight down from the tibia into the rest of the foot. So the first bone that we're going to look at is the talus. So as I mentioned, this is the most superior of all of the tarsal bones, and it's the bone that directly meets up with or articulates with the bones at the ankle, mainly the tibia and the fibula. Now you may notice that this is a nice square-shaped appearance where these bones meet up, and the tibia is going to have an extension that reinforces this joint medially, known as the medial malleolus, while the fibula reinforces this joint laterally at the lateral malleolus. And this is truly our ankle, which allows for both dorsiflexion and plantar flexion of the foot. Now, our foot is also capable of additional movements, and those movements are going to occur in a different position known as the subtalar joint. And this is one of the joints in our foot that is going to allow for rotational types of movement, otherwise known as inversion and eversion. And what we can see is that the talus is going to actually meet up with two bones. Anteriorly, it meets up with a small boat-shaped bone known as the navicular. And you may recall that this sounds something like navy, which means ship in Latin. And thus the navicular has this nice, smooth, kind of canoe or boat-shaped appearance, and it's located anterior to the talus. If we were to go inferior to the talus, this would be the location of the large heel bone, known as the calcaneus. And recall that the calcaneal tendon from the posterior calf, also referred to as the Achilles, comes down and attaches to the calcaneus. So you can imagine that weight distribution is going to come inferiorly and posteriorly through the talus down into the calcaneus, or it could come anteriorly through the talus towards the navicular bone. Now, the navicular bone is going to be positioned on the medial aspect of the foot, and we can see that anteriorly it meets up with three more of the tarsal bones, and these are known as the cuneiforms. We have a medial cuneiform, an intermediate cuneiform, and a lateral cuneiform. Now, note that those references of medial and lateral are related back to the midline of the body. And even though this is not the most lateral bone in the foot, it is more lateral than the other two cuneiforms. And we can see that each cuneiform is going to meet up with its own individual metatarsal. And there is some amount of overlap between these bones where they meet. However, it's more or less a 1-to-1 ratio between these first three digits and the three cuneiforms. The last of the tarsal bones is the cuboid, and this is the square-shaped bone on the lateral aspect of our foot that meets up with the fourth and the fifth metatarsals. Note that posteriorly the cuboid is also going to be articulating with the calcaneus. So the 7 tarsal bones are designed to help distribute the weight from the rest of our body, and they each have a unique position and orientation that will just be a matter of repetition to understand until you can relate these back to their anatomical position. In addition to the 7 tarsal bones in our foot, more at the heel or articulating at the ankle, we also have 14 additional phalanges, or the small bones in our digits, as well as 5 metatarsals. Now, the metatarsals are going to be numbered beginning medially and working laterally. And the first metatarsal is going to meet up with the bones of the big toe. Now, we would continue progressing laterally with the second metatarsal, the third, the fourth, and ending with the fifth. So the fifth metatarsal is going to be with our small digit, or otherwise known as the pinky, and this would be on the lateral aspect of our foot. And you'll see that there's a difference in appearance of this fifth metatarsal compared to the other metatarsals. And that extension on the lateral aspect of this bone is for muscle attachments from the lateral aspect of our leg. Now, the metatarsals are going to meet up with the phalanges. And what we're going to see is that 4 of the digits, beginning with our second on out through the 5th, are each going to have 3 bones. We have a proximal phalanx, a middle phalanx, and a distal phalanx, meaning that we're going to have articulations between these bones at multiple points. Now, the great toe, or the big toe, otherwise known as the hallux, is going to only have 2 phalanges. So we will have a distal phalanx and a proximal phalanx. Now, what we're going to see as we look at the joints in the foot is that these are going to have specific names. So where the metatarsals meet up with the phalanges is the metatarsal phalangeal joint. In the digit itself, between the proximal phalanx and the middle phalanx, this is going to be the proximal interphalangeal joint, while between the middle and distal phalanx will be the distal interphalangeal joint. Now, as you may notice, the hallux, or the great toe, only has 1 joint in between its phalanges. So this is known as the interphalangeal joint. So keep in mind the different joints that will help you remember the movements at these positions in the foot, as well as the different bones that will be found between them in the toes. So recall that there are only 14 phalanges because the great toe does not have a middle phalanx. Also, beginning medially, working laterally is how we number not only the toes, but the metatarsals, beginning with number 1 medially and ending with number 5 laterally.